Warm greetings to everyone. Today, we will be delving into the topic Guided Tissue Regeneration (GTR) with your presenter, Dr. Radhika, Associate Professor from the Department of Periodontics, Chettina Dental College and Research Institute. What is GTR? World Workshop in Periodontics in 1995 defined GTR as a procedure attempting to regenerate lost periodontal structures through differential tissue response. Procedures attempting to regenerate lost periodontal structures through differential tissue response, given by GPT in 2001. Barriers are employed in the hope of excluding epithelium and connective tissue from the surface in the belief that they interfere with regeneration. This method is derived from the classic studies of Neumann, Linde, and Gottlow and is based on the assumption that only the periodontal ligament cells have the potential to regenerate the attachment apparatus of the tooth. History. In 1976, Seltzer described the basic concept that lead to development of GTR, whereas in 1982, Nyman et al. First described the clinical procedure of GTR using a non-observable barrier used in periodontal surgery, which allows regeneration of cementum, periodontal ligament, and alveolar bone was used with the help of a cellulose acetate laboratory filter, which is also known as millipore filter. In 1982, W. L. Gore and Associates began investing materials that would limit the migration of epithelium around dental implant and teeth. This slide shows the various history of development of GTR. In 1982, EPTFP was introduced. In 1982 era of tissue reintegration was discovered. In 1983, era was called era of cell separation. In 1985, era of clinically manageable membrane development was done. Gottlow et al. In 1986 coined the term guided tissue regeneration, and it is also referred to be selective cell repopulation or controlled tissue regeneration. The biologic concept or foundation of GTR. Principle of GTR is based on the assumption that only the periodontal ligament cells have the potential for the regeneration of attachment apparatus of tooth. It consists of placing barrier of different types to cover the bone and periodontal ligament, thus temporarily separating them from gingival epithelium. Excluding the epithelium and gingival connective tissue from the root surface during the post-surgical healing phase, it prevents the epithelial migration into the wound, favors the repopulation of the area by the cells from periodontal ligament and bone cells. Guided tissue regeneration with the use of barrier membranes work on the principle of cell exclusion, particularly of epithelium type. Melcher's concept or tissue compartment hypothesis. Melcher's hypothesis in 1976 suggested that a paper, that is a type of cell which repopulates the most one after the periodontal surgery, determines the nature of the attachment that will occur. Root surfaces may be repopulated by 4 different types of cells. Example, epithelial cells, cells derived from the gingival connective tissue, cells derived from the bone, cells derived from the periodontal ligament. Indication. GTR is indicated in 2 or 3 wall intrabony defect, class of bifurcation defect, recession defect, alveolar ridge augmentation, to fix gingival biotype, to repair of apicectomy defect. Contraindication in scenarios such as infection at the site of defect, poor oral hygiene, smoking, tooth mobility, perforation with short root trunk, horizontal bone loss, multiple defects, etc. Design criteria for GTR devices. Gemma and Hadwell in 1982, they mentioned the various criteria for GTR devices. Example, biocompatibility, cell exclusion, space maintenance, tissue integrity, ease of use, etc. Whereas Cotan in 1993 mentioned that biocompatibility, cell occlusiveness, space making, tissue integration, and clinical manageability are the basic primary criteria for GTR devices. Objective of an ideal barrier membrane. It should fulfill occlusive requirement of GTR concept. It should be biocompatible and or allow tissue reintegration, non-toxic and non-carcinogenic in nature, chemically inert and non-antigenic, partially sterilizable, easy to handle during surgery, easily available with a long shelf life, should not be too expensive, and able in a case of complication. Classification by Minabe in 1991. Bioabsorbable are two types, such as natural and synthetic. Under natural, the examples of GTR membranes are collagen type, uh, and under synthetic, the examples are polyurethanes, polylactic acid, polyglycolic acid. Advantage and disadvantage of non-resorbable membrane. The advantages are excision of epithelial and gingival connective tissue from the periodontal defect, maintains space between the defect and barrier, allowing entry of cell from the periodontal and alveolar bone, helps to stabilize clot which may enhance regeneration, space maintenance over an extended time. Whereas the disadvantages are membrane exposure, contamination, infection, and further bone loss. This slide also mentions the various advantage and disadvantage of resorbable membrane. The advantages are reduced operatory time, more tissue compatibility, reduce the risk of loss of regenerated attachment to re-entry surgery. The disadvantages are resorbable in nature, high cost, instability of barrier, lack of stiffness. Factors affecting the outcome of GTR are patient factor, defect factor, and surgical techniques. The primary factor affecting the clinical outcome of periodontal surgery have been classified by Conman and Robertson as bacterial contamination, innate wound healing potential, local site characteristics, and surgical procedure. Past principle. Horn and Lehmann and Boyapati in 2006 have suggested four factors that play a critical role in regeneration. PASS. P means primary wound coverage or passive flap tension. A stands for angiogenesis. S stands for space maintenance. Another S stands for stability. Healing of GTR treated bone defect. Following initial organization of blood clot, the membrane regeneration was initiated by deposition of open bone, allowing new vascular structures originating from the bone wall. The primary was characterized by blood vessels originating from the marrow spaces. The network of open bone was reinforced by concentrically deposited parallel liberated lamellar bone, which resulted in development of a new cortical structure at the periphery of defect. The onset of bone remodeling with the formation of secondary osteons could be observed in the newly formed bone close to the defect margins. The duration of the maturation process exceeds 4 months in a larger defect. Given by Schenk et al. In 1984. Types of complication such as pain, swelling, abscess formation, apical perforation of flaps, flogging, perforation, root resorption, and ankylosis. These are the complications associated with the membrane exposure. Evaluation of GTR treatment outcome by clinical methods such as probing, bone level, re-entry procedures, bone sounding, radiographic bone changes, histological methods, and re-entry surgical site. Current status or current advances in GTR, such as GTR incorporated with tetracycline, membrane containing metronidazole, incorporation with chlorhexidine into GTR membrane. Conclusion. The principle of GTR lies in the establishment of cells of periodontal ligament to selectively repopulate the root surface. Thank you for listening.